Thank you so much for the invitation to be here today. It's such an honor to be part of a lectureship that has an almost 60-year history. And it's super fun to be back here at Stanford and see so many friendly faces in the audience who I know I wouldn't be here without your guys' support. Here are my disclosures for today. And I just want to start out by thanking, in particular, the Stanford 25. So this is a picture of me at their first clinical skills symposium back in 2015, so 10 years ago. And we're going to talk about AI in medicine a little bit later today, but I just asked AI what they thought of this picture. And it's a group of people sitting on stools. But you probably recognize some of the most influential people in bedside medicine over the last decade. So Abraham Verghese, who needs no introduction here or probably anywhere. Stephen Russell, who's at University of Alabama. He's an author. He's med-peds, rheumatology trained, and he was actually a two-time president of the Society of Bedside Medicine. Andrew Elder, who's the president of the Royal College of Physicians of Edinburgh, which is one of the oldest medical societies in the world. Maya Artandi here at Stanford is also, I think you're a two-time president as well for the Society of Bedside Medicine, or you had like just a really long reign in your presidency. And then Steve McGee, who, if you're familiar with his evidence-based physical diagnosis, really is one of the best texts ever written about the evidence behind what we do at the bedside. And the community that was built through this initial conference and subsequent conferences really changed the course of my own career. The mentorship, the camaraderie, the fellowship, the guidance, the inspiration, particularly from the Stanford 25 group. Thank you all. I know that I wouldn't be here if you hadn't invited me, but I don't think you would have invited me if you hadn't inspired us to do some of the work that we've done together. And it made me start reflecting back over, this is me sitting here wondering, how did I get on this stage? So I was thinking back to other points in my career where you kind of look around and you're like, how did this happen? And Pedram sort of spoiled this a little bit, but 5 years after that first conference, I found myself at Walter Reed as part of the president's care team when he had COVID-19. And I don't think I'm legally allowed to talk to you about anything that happened there. Actually, I know I'm not legally allowed to talk to you about anything that happened there. But I did want to tell you a funny story. So we didn't tell anyone, my wife and I didn't tell anyone that I was involved in the president's care until the first press conference. And you can imagine that after this aired, I got a lot of text messages, a lot of phone calls. And so I had to prioritize, obviously, calling my mom back after I talked to the kids. And this will give you probably a lot more than I probably should tell you about what it was like growing up with Queens with Kathy Garibaldi, who's amazing. But she called up and she said really quickly, "We're very proud of you, son. You got to do something about the microphone." And I'm like, what are you talking about? She's like, "I can't see your face on TV. I want to get a picture of your face on TV." I'm like, "Mom, you've seen the Walter Reed doctors. They're all like 9 feet tall. Like, this is the best that we're going to do." She's like, "You have to do something about this." So you have to imagine, you can imagine that the lieutenant who's in charge of communications at Walter Reed is quite busy at that particular time period. But I tracked her down and she was so nice. And I told her what my mom had requested. And the next day, she got this tiny little microphone. So anyway, maybe in the Q&A, I can answer some questions about that. So what I'd like to accomplish in the next 40 minutes or so, or maybe 35 minutes, is talk about the current state of where we are at the bedside encounter, talk about the importance of a hypothesis-driven approach to the bedside encounter, summarize the role of technology, talk a little bit about assessments, very briefly touch on the power of being at the bedside beyond its diagnostic importance, and then invite you to join what I hope continues to be a growing community around bedside medicine. And so I wanted to start with a quote that I first heard when I was in medical school at Johns Hopkins about 25 years ago. Sir William Osler said that medicine is learned by the bedside and not in the classroom. Let not your conceptions of the manifestations of disease come from words heard in the lecture room or read from a book. See and then reason and compare and control, but see first. And this is an iconic series of pictures of Osler at the Johns Hopkins Hospital in the early 1900s, engaging in the 4 cardinal maneuvers we think about when we're at the bedside. He's observing, he's palpating, he's auscultating, and he's contemplating. But if we go over to the hospital anywhere in the world, including here at Stanford, this is probably what we're going to find, right? We're going to find, particularly our trainees and junior doctors, spending upwards of 50% of their time engaging in the care of the digital patient, or the eye patient, as Dr. Verghese has coined. And it's not surprising, that if we spend this little time with patients, fundamental skills that can only be practiced in the presence of patients are in decline. We did a study a few years ago where we had our interns wear tracking badges. And I'm going to show you some of this data a little bit later on, but this is sort of the summary data. they spend only about 13% of their time in direct contact with patients. And so there are many different data sets you can look at that talk about the decline in physical exam skills. This is one about the cardiovascular exam, which is an online test that uses videos of real patients who have real cardiac findings. You can move the stethoscope around and listen across the recording, and the camera angle changes so you can look at the neck and the chest. And when you plot performance on this exam on the y-axis compared to when you graduated from medical school, there's a straight line down over the last 50 years, right? And this decline has consequence. You know, it's estimated that there are about 18 million diagnostic errors that are made in the US each year. They're so common that each one of us in our own experience as a patient will almost certainly experience a diagnostic error. And when people have looked at where these errors are happening, about half of diagnostic errors, at least in some outpatient studies, are related to a mistake in the physical exam. And when Dr. Verghese and others have looked at what are the most common mistakes in the physical exam, the most common mistake is simply that the exam was never performed. And I think that's worth repeating. The most common mistake is that simply the exam was never performed. And it's gotten so common that Dr. Verghese had this cartoon commissioned a few years ago that says, let's get a CAT scan and consult the gastroenterologist and figure out why you're having these pains. But this, you know, this is an extreme example, but we've all been in this situation where we become so reliant on technology to make diagnoses that we begin to doubt what we see, what we feel, what we hear, maybe what we smell, hopefully not what we taste. You shouldn't be doing that at the bedside anymore. And then this happened. So I was fortunate enough to be part of a special pathogens group at Hopkins. We were the first unit to take care of COVID patients in Maryland. And about a week before we got our first patient, we were invited to be on 60 Minutes. So these are two of our nurses and two of my good friends who are demonstrating how to get in and out of gear. And very soon after this, we opened up a series of COVID ICUs. And this is a real note from one of our ICUs. Physical exam, intubated, sedated, prone, rest of exam deferred secondary to COVID precautions. The other thing that happened, which was very different from the 1918 influenza pandemic, is we sent all of our students home, right? Everyone went remote, right? And I'm not criticizing that decision. We had to do it by April of 2020. I was wearing a Ford Motor Company airbag that was sewn together to be an isolation gown. We simply did not have the gear to keep our students safe. But now we're faced with, we already had a problem with the way that we were approaching bedside skills. And then some of our junior doctors now and some of our senior residents and fellows missed a year of fundamental formative experience. And when they came back to the hospital, the way that we were approaching bedside care had changed fundamentally. So as I mentioned earlier, I've really benefited from being part of the community that really started here at Stanford. We're part of the Society of Bedside Medicine, which is a nonprofit we started back in 2017, really came out of the Stanford 25 Clinical Skills Conference. And through the work that we've done together over the years, I was invited to start a new center for bedside medicine at Northwestern. And what I wanted to share with you are some of the guiding principles that we've developed through the society and now are continuing to develop at the center, and use that as a framework to talk about building community around bedside medicine. So the first is to go to the bedside and observe, right? And this is a picture of Charles Horace Mayo at the bedside examining an infant. And the bank robber, Willie Sutton, was reputed to have said in response to the question, why do you rob banks? And he said, that's where the money is. Now, it turns out he later in life said, I never really said that. The reporter just made that up because it would sell copy. But I think if you want to get good at bedside skills, you have to go to the bedside because that's where the patients are. And observation is one of the most important things that we do at the bedside. This is from Steve McGee's Evidence-Based Physical Diagnosis. And he wonders about why we've become over-reliant on technology or why we started to doubt our own senses at the bedside. And it's probably because 100 years ago in the time of Osler, almost all diagnoses were made through bedside observation. So Osler himself probably died of post-influenza bacterial pneumonia. He had a bedside thoracostomy performed in his bedroom, and x-rays were available or starting to become available, but he never had a diagnostic test, right? Everything was done through the physical exam. And in marked contrast today, the majority of what we do in diagnosis probably made through a technology-based test or remote from the patient. And this has led to the false assumption that if it's done through tech, it must somehow be better, right? And sometimes it is, but not always. So what's this? Thank you. I saw a lot of mouths moving and I think I heard that. So this is zoster, right? You have the right clinical context, you see this rash, you're done. That's the diagnosis. This is the gold standard test. Could you do a Zank smear? Yes. Could you do a PCR test? Sure. But you don't need to. You have the diagnosis. And there are many times where bedside observation is as good as technology. And so this is James Parkinson's essay on the shaking palsy. And I learned this actually at the first Stanford 25 conference when Steve McGee was giving a talk on Parkinsonism. And he asked the group, do you know the one finding that James Parkinson did not describe in his seminal essay on Parkinson's? Yeah, it wasn't tremor. You could see tremor. It was cogwheel rigidity. And so some people have taken that to infer that perhaps he actually never touched a patient. He was so good with his observation skills that he was able to come up with identifying a clinical syndrome just by observing people. So forgive me if you've seen this before. This is a video that was sent to me by Andrew Elder. I'm not sure if you can see that from where you guys are. Can you guys see that okay? Maybe? So there are 3 cardiac diagnoses you can make just by looking at this patient's neck veins. I'll just shout out some things that you see. Yeah, so this person has tricuspid regurgitation. This is Lancisi's sign, the systolization of the big V wave, right? So that's number 1. That's probably the hardest one to get. Let me play it again so you can see it. What else? Do you normally see the ear move like this from your jugular venous pressure? Probably not, right? So this person's jugular venous pressure is really high in association with their tricuspid regurgitation. And then the last thing is, it's really hard for me to predict when the next beat's going to happen. Right? So this person is in atrial fibrillation. So just from looking at this person in 30 seconds, you could make 3 pivotal diagnoses before you even talk to them. And so, but as a profession, we're probably less acute in our general observation than was the practitioner of the old school. And this was said by Charles Horace Mayo in 1916, right? And so I think we really need to revisit the way that we approach observation skills. And a lot of it has to do with spending time with patients, but there's lots of emerging data about how we can improve our observation skills in non-medical contexts. So Stephen Russell, who, as I mentioned earlier, is one of the current presidents of the Society of Bedside Medicine, he and many others have developed ways of looking and observing and thinking about what we see, and have shown that if you do that in a museum setting, for example, by looking at art, you actually become better at identifying clinical pathology at the bedside. The next thing that we need to think about is, how do we practice and teach an evidence-based approach to the bedside encounter and the physical exam in general? And the first question is, does this stuff still matter, right? You know, people ask me all the time, in the age of all the wonderful technology that we have, does doing a good history and physical still matter? And there isn't a ton of evidence out there, but the evidence that is available suggests that yes, it is still a really fundamental part of what we do. So this was a study that was done in an ER setting about 15 years ago, where they looked at almost 400 consecutive patients who came to the ER and got admitted, so they could adjudicate what the final discharge diagnosis was. And then they looked back at the resident, the senior resident, and the attending who admitted those patients, and they looked at what their initial diagnosis was. And 40% of the time, a history and physical got them to the right answer. If they layered on just very simple testing like a urinalysis or an EKG, they got the right diagnosis 70% of the time. Another way to look at this is to kind of look at the things that we sometimes miss if we don't do a good job at the bedside. So this was a study that was done by Brendan Riley at Cook County Hospital. This is the hospital that inspired the show ER. Is anyone watching The Pit right now? So I'm totally dating myself, but Noah Wiley, who's the protagonist on The Pit, he was a medical student in the original ER show back in the early 90s. So it's kind of wild to see him kind of evolve. And so what Dr. Riley did was he looked at 100 consecutive admissions by an overnight resident team, and then he looked to see what changed when the attending physician went to the bedside and examined them. And about 25% of the time, pivotal physical findings had been missed overnight that dramatically changed management. So someone with fever who had an aortic regurg murmur that clearly showed they had endocarditis, someone with cellulitis who ended up having Fournier's gangrene and had to go to the operating room, right? So these things still very much matter. Justin Choi, who's one of our bedside medicine scholars, I'll tell you about this program towards the end, he did a 200-hour ethnography study of handoffs of care between the night team and the day team. And the day team didn't always go to the bedside, but when they did, he found the same exact thing. 20% of the time, going to the bedside, talking to the patient and examining them led to a fundamental change in the differential diagnosis. So why is it that we don't think about the exam like other diagnostic tests? Well, part of it is the way that we teach it in medical school traditionally, and this is changing, but traditionally we teach it as a series of maneuvers that you do head to toe. You have a day on the abdominal exam, a day on the chest exam, a day on the head and neck exam, and we teach it without context and without linking it to pathology. And that's not the way that we use diagnostic tests at the bedside. So if you want to use the physical exam like another diagnostic test, you need to first think about what your pretest probability is. And at a basic level, this could be the prevalence of disease in the patients that you're seeing. So for example, someone who shows up with cough, what's the prevalence of having, pneumonia if you have fever and cough? You have to use your own context to modify that. I worked in a pulmonary fibrosis clinic for many years. So if someone got to my clinic with cough, my pretest probability for IPF was really, really high, but it shouldn't be that high if someone presents with cough to a primary care provider for their first complaint of cough, right? And then you choose the appropriate physical exam maneuver to help modify that probability. And then finally, you use the performance characteristics of that test to determine the post-test probability. The best way to do this, I think, is to think about likelihood ratios. I'm not going to go into the derivation of these. If you're interested, Steve McGee's book is just a wonderful chapter on the derivation of likelihood ratios and how to use them. But the general idea is that you can take the sensitivity and specificity of a test as compared to a diagnostic gold standard, if such a standard exists. And then if the likelihood ratio is greater than 1, it increases the probability of disease. If it's less than 1, it decreases the probability of disease. So I'll give you an example of how maybe not to use this. So let's imagine we're seeing a patient who's got abdominal distension, and we want to figure out if they have ascites. Has anyone ever heard of the puddle sign before? So I had a chief resident when I was a senior resident who talked about the puddle sign all the time. Anytime someone had abdominal distension, he would say, hey, does he have a puddle sign? And we used to run notoriously late at Hopkins. So it was late on a Thursday evening. And Martine asked me about one of our new admissions who had alcoholic liver disease. He was encephalopathic and coagulopathic. Does he have ascites? I was like, Martine, I don't know. The ultrasound hasn't been done yet. He's like, well, does he have a puddle sign? I said, I don't know how to do that. You talk about it all the time. Can you show me how to do this? And so the way you do a puddle sign is you take this person who you think has ascites, you get them on all fours, you let them stay there for a few minutes, the idea being that any fluid's going to pool at their umbilicus. Then you get down on the ground on the hospital floor with them. You put your stethoscope on their belly button and you start to flick, and you listen to when the sound changes from resonant to dull. That's the air fluid level. So we try to do this on our encephalopathic coagulopathic patient. I get down on the ground, I'm about to give him his first flick, and he just face plants. And if I'm being honest, I don't remember if the flick was what caused the face plant. And his nose just explodes, blood everywhere. We had to call ENT to pack his nose to stop the bleeding. And then when the dust settled, I went and looked up the evidence for the puddle sign. And I'm adding this to Steve McGee's book. The likelihood ratio is like 1.1. It does not change your ability to detect ascites. And the reason I tell this story is if we know for sure that an exam maneuver is unlikely to change our diagnostic impression, and there are other ones that are better, we should focus on learning the ones that have good evidence behind them. And if you get rid of everything to look for ascites at the bedside, and you remove anything that doesn't move the needle by 25% or more, you're left with just 3 things: the absence of edema or the presence of edema that helps you increase or decrease probabilities. Do they have a fluid wave, and do they have flank tympany? Now, as we'll talk about in a few minutes, if I really cared if this person had ascites, I would just grab a hand-carried ultrasound or a cart-based ultrasound and put the probe on their belly and see if they had ascites, right? We already talked about how we have very little time at the bedside to practice these skills. So if we want to get better, we have to intentionally practice our physical exam and clinical skills. So when I was a junior faculty about 15 years ago, we started a curriculum trying to marry clinical reasoning with bedside physical exam maneuvers. And I'm a pulmonologist, so we're not really good at acronyms. This is actually what the program was called. It was clinical reasoning applied. You know where this is going? To the physical exam, right? And so then a cardiologist joined our team, and he's like, what are you doing? Like, we can do better than this. And he came up with this really complicated acronym that we called ACE. And this was a 2-week curriculum that we had for our interns on the Ulster Medical Service, which consisted of a series of experiences every morning for half an hour. Sometimes it was a simulation with Blaufus, sometimes it was the Harvey mannequin, sometimes it was with healthy volunteers. This is me 10 years and 30 pounds ago. But most of the experience, about 80% of our sessions, were at the bedside with real patients, where we could talk about how what we saw and what we examined and what we learned from talking to them impacted diagnosis. And what we assessed using this online cardiovascular skill was only the interns who went through this ACE curriculum that improved their overall skill. So intentional practice does improve your skill. And we've tried to do this here at Northwestern. We are very fortunate with our Center of Bedside Medicine. We actually have dedicated faculty support to recruit faculty at about 10% effort to come and help us think about bedside clinical skills. So I'm showing 8 of our faculty here to demonstrate the diversity of skill sets that people have. We have hospitalists, we have cardiologists, a dermatologist, pediatrician, a neurologist, a rheumatologist, a vascular surgeon, and an endocrine surgeon. And I'll show you some other people in a little bit. And we're just going around teaching learners at the UME level, the GME level, and doing faculty development, spending time with people at the bedside. And how do we do that? Well, one of the things that we rely on very heavily actually is something called the 5-minute moment. I see some smiles. Obviously you guys created the 5-minute moment. The idea being that you could take a physical exam maneuver or a sign, ground it in historical context, make a technique base so someone can demonstrate back the technique to you, and then talk about why that finding might be important. We use a lot of these. And if we have more time, you can string several together to have a deeper session. But we've also taken advantage of traditional conferences. So this is an example of morning report. For decades, we didn't have morning report at Hopkins. Before the pandemic, we started doing it again, but we tied the morning report session. You had to have a patient who was still in the hospital who was willing to have us go examine them. So we went through a traditional morning report, came up with our differential diagnosis and the rationale for why, and then talked about things that we might want to confirm or do additionally at the bedside. And then we'd all go examine the patient, and we'd use technology to do that. This is us with a digital stethoscope and a headphone splitter. And we found the same thing that those prior studies have found. When we went to the bedside and did this about 20% of the time, we found something that markedly changed the differential diagnosis. The most extreme case was a woman who came in with dehydration and renal failure. We went to examine her, and she had pulmonary hypertension and right heart failure, and within 5 minutes of our session was up in the ICU on inotropes, right? Because we had missed those findings overnight. I did want to briefly mention it's not just about physical exam maneuvers. So we're really blessed at Northwestern. There's an existing program called the Align program that's run by 2 of our palliative care hospitalists that really focus on advanced communication skills at the bedside, and they're now part of our center. So we're really happy to partner with them about this. It doesn't have to just be in-person experiences with real patients. So you guys are the leader. If you ask anyone, like, what's the best resource for learning how to do physical exam maneuvers, they will tell you the Stanford 25 website. I was just talking to Errol about this. They've had well over 13 million unique visits to the site, 5,000 visits a day. Like, you guys are the gold standard. There are others who are also providing really good content. I wanted to highlight Andre Mansour's Physical Diagnosis, or PDX, which is a really wonderful site that also has a really nice repository of physical exam findings. And so you can use these as part of an integrated lecture, or as just something you can do remotely to try to enhance the way that people think about these skills. And so that's a nice segue into using technology, right? I love this picture. This is Rene Laennec, and this is him holding his monaural stethoscope in his left hand, that wooden tube, but he's still engaging in direct auscultation on a patient who probably has tuberculosis. And I love this picture because it talks about the intimacy of physicians and patients. People have lauded the stethoscope as maybe the single greatest technological invention in medicine, at least through the 1970s, let's say. But some people have also decried the creation of the stethoscope as the first time that there was an inanimate object between a patient and a physician. I like to think of it as the reverse. I like to think of it as something that connects us to our patients, as Jeremiah Barondis talks about. It also is, I think this picture is a good reminder, sometimes people, are concerned about the impact of personal protective equipment on our ability to use our hands and to hear and to see. Shortly after this was painted, Laennec himself died of tuberculosis. So PPE can be very important, as we all learned during the pandemic. A lot of people think the stethoscope's dying. There's a lot in the media about 8 or 9 years ago, around the 200th anniversary of the stethoscope. I think these are misguided. The stethoscope still has an important role in what we do. It's not going anywhere. Last year, or during the pandemic, stethoscope sales were close to $1 billion, and more than half were analog stethoscopes. But the stethoscope has evolved. So this is a digital stethoscope that's taking a recording and shows you a spectrophotogram. A patient who had fever has a diastole. This person had aortic valve endocarditis. And some of the newer stethoscopes actually project an EKG at the same time. And so you can be in a room, you can Bluetooth your digital stethoscope to a speaker and to an iPad, and you can show someone the spectrophonograph, the EKG. You can all listen to heart sounds. It's an incredible way to enhance your own diagnostic skills, but it's also a great way to engage a whole group of people instead of us all standing in a line saying, "Hey, John, did you hear that?" And you're like, I don't know, but I'm going to say yes, right? It's a much more effective way to teach. But I do think if we talk about technology at the bedside, ultrasound has to be a part of what we do. So this is a real case from our ICU at Hopkins from a few years ago. This is a 43-year-old female who had MRSA pneumonia, who was intubated with ARDS. And then overnight, she developed increased work of breathing and hypoxia. And so the overnight team was just heavily sedating her to try to deal with this vent dysynchrony. And they were considering paralyzing her. And we came in the morning and we went to see her first on rounds. And we could see from the foot of the bed that the left side of her chest wasn't rising. Put her hand on her chest, it wasn't moving. Tapped on her chest, it was really resonant. Put a stethoscope on the chest, didn't hear any breath sound. So what does she have? She's got a pneumothorax, right, from her necrotizing pneumonia. And so we grabbed an ultrasound machine, and this is what we saw. So just to orient everybody, this is the pleural line here. And what you're seeing is the aerated lung slide into this pneumothorax. This is what we call lung point. And if you see this, oh, thank you. This is pathognomonic for a pneumothorax at that point. Now, ironically, this is before I was credentialed to do chest tubes. So we called the person on call to do chest tubes that day. And this was about 5 or 6 years ago. They did not yet appreciate the power of ultrasound. So we had to wait 20 minutes to get this chest x-ray that showed the large pneumothorax, with me standing at the bedside with a 14-gauge angiocath ready to do a needle decompression if she decompensated. This case inspired me to go get my chest tube credential. So we are blessed at Northwestern to have 2 national experts in ultrasound who are designing a longitudinal faculty development program with support from the Dixon Family Foundation to do longitudinal faculty training, train the trainers across the health system, not just in the emergency department, but in other divisions, to try to bolster our ultrasound skills. I love ultrasound because it helps you make diagnoses that you can't see, hear, or feel sometimes. But I like it even more because it builds connection, not just to patients, but to learners. I have yet to meet an ultrasound machine that you can use remotely, that you can use through clothes, right? So you have to go in the room, you have to build rapport with the patient, you have to appropriately drape the part of the body that you want to scan. And in doing that, you almost always find something else that helps you understand that which you're probably going to see. You already suspect before you put the probe on the chest. The other thing I love about it is that everyone wants to learn ultrasound, right? So if you say, hey guys, let's go ultrasound a patient, I can dangle that in front of them and gather everyone to the bedside. And then I can force them to listen to me talk to them about other things that they should know about this patient before they put the probe on. And hopefully you can get buy-in. The other great thing about it is that patients can be engaged about their disease. They can see the fluid collection around their lung that you think has to be drained. They can see that their heart is not squeezing well. They can see the large vegetation on their aortic valve and understand why they need to have surgery. Just a wonderful tool. So I'm going to briefly talk about AI. We could spend the next hour, 10 hours, year talking about, actually it changes every 5 seconds. But this is Moxie. This is our pharmacy robot at Northwestern. I'm totally dating myself by saying this, but the past always predicts what tech looks like. She looks exactly like Rosie from the Jetsons to me, right? Except she has one arm. I don't understand why she has one arm. And I've been trying. My office is actually right near Moxie's home base, and there's actually 5 Moxie robots. And I've been trying to get a selfie with Moxie for 6 months, and I just cannot figure out how to get her to stop. I show this picture to my wife. She's like, "Why is the one-armed robot giving you the finger?" But I was actually walking with someone from media the other day. We were just going to get some coffee, and I told her about this. She's like, "Oh, I know what to do." And so Moxie was coming down the hallway. She took off her backpack and just threw it on the ground in front of the robot. And then we snapped this selfie. And I don't know if you noticed, but her eyes went from blue. She gave me pink hearts. So that sort of made my day. So I was going to show this. I was going to talk about this. One of many studies, Google AI has better bedside manner than human doctors and makes better diagnoses. But then my brother, not realizing I was on the West Coast, sent me this text this morning with this meme that said, "Your future doctor is using ChatGPT to pass medical school right now, so you better get started eating healthy and exercising." All right, and I think what this says is, for me, as we begin to use these tools to help us with integrating vast amounts of data and coming up with differential diagnoses and improving clinical reasoning, what's going to become even more important is our ability to gather that primary information at the bedside. So no matter what these AI tools look like for the at least foreseeable future, our ability to connect with patients, our ability to ask the right questions, our ability to see things, feel things, and hear things, and yes, using AI-empowered stethoscopes and ultrasound. That needs to be our focus so that what we put into these models is actually accurate, right? And so we're thinking about how do we use AI to teach these observation and physical exam skills. So we're lucky to have Courtney Reamer and Gopi Astik as part of our center. And Courtney's an informatics fellow, and she, after just kind of chatting about this issue, she went home and like a week later said, hey, I've developed a prototype app that right now you have to input clinical information, but eventually it will just pull in information from the electronic health record, and it will suggest to you a differential diagnosis, and then link out to really high yield resources that we curate to suggest, hey, if you're worried about these 3 differential diagnoses, have you thought about doing these 3 or 4 physical exam maneuvers? I hope it's okay. It's already linked to the Stanford 25 video collection and PDX, right? And you're going to be able to use this app to help guide your diagnosis decisions, but also to teach you how to acquire information to prioritize your differential. But we can also use technology to help us understand the clinical environment, both the educational environment as well as clinical operations. This is data from that RTLS badge tracking study, the real-time location system study I alluded to earlier. And we had 43 interns who wore the tracking badge over the course of their intern year. We had over 2 million observations. We had over 100,000 hours of data on how these interns spent their time. And what I've done here is I've lined up all 43 interns from the person who spent the least amount of time at the bedside, number 1, to the most amount of time at the bedside, number 43. And if you make some assumptions about the total amount of time that people spend in the hospital, 48 weeks a year, 80-hour max work week, intern number 43 spent almost 6 weeks more time at the bedside than intern number 1, right? There has to be something different about their experience as a trainee, how they approach their encounters with patients, how the patients experience those encounters, and we're trying to figure out what that means, and can we tap into that to improve the learning environment. I'm going to very briefly go through some new data that we're working on using about 1,000 shifts across 30 residents who wore these badges over the last couple of years. So this is Mike Rosen, who's a human factors engineer at Hopkins. And so he took average time in the patient room per person. He took average time in the workroom. He used a measure called burstiness, which tells you how much time you spend in one place. So if your burstiness is high, that means you sat in one place for a really, really long time. And then he looked at total EHR time. And across these 1,000 shifts, he basically identified 3 types of shifts. So this shift here, you're spending a little bit more time than average in the patient room, not a lot of time in the workroom. You're not very bursty, so you're moving around from place to place, and you're spending a little bit less time in the EHR. In contrast, this type of shift, you're spending little time in the patient room, a lot of time in the workroom. You're very bursty, which means you're sitting in the workroom the entire shift, and you have more time in the EHR. And then sort of somewhere in the middle, right? And he took all 30 of those residents, and he was able to predict which shift they were likely to have. And so there are basically 2 patterns. The pattern on the right is someone who spends most of their time in this first profile, where they're very patient focused, not a lot of time in the workroom. And the person on the left has a mix of 2 types of shifts. Some shifts, they're spending a lot of time with patients, some shifts they're not. And now we have data on professional fulfillment and burnout and clinical skills that we're going to layer on top of the predictions of these shifts to see, does a particular shift type actually correspond to the way you feel about your job or the way that you're learning about your skills? So more to come on that. If we care about these skills and if we care about improving them, we need to do a better job providing feedback on these skills. So this is a picture of my mom as a patient participating in one of our clinical skills assessments at Hopkins. And we don't do a good job of this in the United States. So this is patient care milestone number 2 from the ACGME on the physical exam. And to be ready for independent practice, you have to use advanced maneuvers to elicit subtle findings and integrate subtle physical exam findings to guide diagnosis and management. Well, how do we do that if we don't actually directly observe our trainees talking to patients, examining them, and ourselves examining them so we know if they actually got the right answer from their exam? So which US doctor is competent at the neuro exam? How would you tell? So we have this guy or this guy. And I might even argue that, we use surrogate markers to say if someone's good at the physical exam. Both of these guys actually have reflex hammers, which probably means they're better than average, right? Because most of us, if I asked you, do you have a reflex hammer? Some people might say yes. Most people would say, oh, it might be in my house. And if I asked you to get it in the next 30 seconds, well, actually, you're here at Stanford, so you probably could get a reflex hammer in 30 seconds. I should be careful. This is very different from what the rest of the world does, or most of the rest of the world. So in the UK, or in systems that sit for the MRCP exam, they actually have to pass, graduate trainees have to pass a summative high stakes exam where you encounter real patients with real stories to share, real physical exam findings, and you do so in front of faculty who basically use their judgment to say, are you ready for independent practice? The first time pass rate is only about 60%. And so assessment does drive learning. There is an entire industry in countries that sit for the MRCP around training people to pass. So at the start of medical school, people focus on physical exam skills the way that we focus on pharmacology and biochemistry. There's no appetite for summative assessment in the US. The last time we did this in graduates or in practicing physicians in internal medicine was in the 70s. The step 2 clinical skills exam, which used only standardized patients, went away during COVID and is probably not coming back. But we tried to create a similar experience that would be formative. You'd go through this assessment, and then we would give you real-time feedback to improve your skills. So this is an example of one of these sessions where one of my patients who gave me permission for this photo, he had pulmonary fibrosis, so I had an intern examining him. When she's doing so in front of a junior attending who's now one of our senior oncologists, she was a chief resident at the time, and a pulmonologist who's now retired, Dr. Terry. And after they do this exam, they give her real-time feedback. In this case, most people missed this fundamental finding, this chest wall defect in this gentleman, because when asked to do their best pulmonary exam, 9 out of 10 people didn't take down the gown, right, and missed this really important finding. So we were able to give feedback in real time to the trainees, but then we also pair faculty together and we learn from each other. My neurologic exam is so much better because I intentionally put myself in one of these sessions with a neurologist, right? And my cardiac exam is that much better because I would intentionally put myself in these sessions with cardiologists. So what have we learned? So I think we've learned that the physical exam is still important. So if you plot physical exam technique compared to identifying signs, there's a significant and positive correlation. And more importantly, if you identify the signs that are there, you're much more likely to get the right answer on your differential diagnosis. Just give you a couple quick examples. So we had 109 interns examine the same gentleman with severe aortic regurgitation. And we didn't do so well in terms of identifying signs or coming up with the right answer. Less than half of people came up with aortic regurgitation. And the reason was only half of people heard the diastolic murmur. And the 2 most common mistakes that were made, number one, about 10% of people listened through the gown and none of them heard the murmur. So that's an easy thing to correct. You remove the gown, you listen to the heart, you're like, oh my gosh, I hear the murmur. And the other common mistake, this is going to be a part neuro exam too. Everyone take your left thumb, put it on your right radial pulse. I know your textbooks say don't do, all your fingers have digital arteries, it's fine. And then use your index finger and put on your carotid pulse. And what you will probably notice is that there's a delay between your carotid and radial pulse, right? And so as the heart rate gets faster and diastole becomes smaller, you can confuse systole and diastole if you time the cardiac cycle with the radial pulse. So it's a really easy mistake to make. People had heard a murmur, they thought it was systolic, we moved it to the neck, and all of a sudden they're like, oh my gosh, that's the first diastolic murmur I've ever heard. It's like, no, it's not, but it's the first one you realize that it was diastolic, right? The neuro exam was pretty bad. These are normalized scores to 100, so we did really bad on a neuro exam in a patient who had multiple sclerosis. And as I alluded to earlier, most of our residents didn't have a reflex hammer. We gave them one, but they clearly hadn't used one since medical school. And there's a real thing called neurophobia, right? This has been written about for over 30 years in the medical literature. There's neurophobia for medical students, there's neurophobia for internists, there's neurophobia for neurologists. Talking about neurophobia, this is Junaid Zaman, who's a board member of the Society of Bedside Medicine. So at the first Stanford conference, he examined a patient he didn't know in front of a group of about 250 people. He had to do a neuro exam. And then he was judged by Andy Elder and Abraham Verghese. So that, to me, this is the definition of neurophobia. And I'm really glad they didn't ask me to do that. 2 alarming things, or 1 alarming thing. If you lined up all of our residents by calendar month and looked at their scores, there was a straight line down. Each month further out from medical school, our clinical skills declined. And that suggests to me that we simply are not focusing on these skills when we're out on the wards. During the best year of their training, their skills got worse because they hadn't employed those skills since they were a medical student. That's something we need to correct. The other thing that we've learned is that we compared about 70 residents who did this online cardiovascular test. and who also examined the same patient with cardiac disease, there was absolutely no correlation between performance on the online test and what people did when they had a real patient. So we have yet to find a substitute for direct observation, which is really important, right? Because it's time-intensive, labor-intensive, it costs a lot of money. So that's something we're actively searching for. Can we find a surrogate marker, compare it to these not high stakes, but high resource encounters, and try to scale up our ability to look at clinical skills. The last thing that I'll briefly talk about is acknowledging the power of the bedside beyond diagnosis. People here at Stanford in particular have written a lot about the connection that we get from patients. Dr. Verghese, Dr. Zolman, Dr. Costanzo have written extensively about this. The connection that's important to patients, the fact that a physical exam done well can have a placebo effect and done poorly probably can harm that relationship, but also the meaning that we get as physicians from the time and the connection that we build with patients through speaking with them, through being present with them, through touch. And I truly believe that a big part of the rise in stress and burnout that we're seeing amongst trainees and junior physicians is related to this lack of connection. And I think the way back is through being at the bedside. This is unpublished data from our study at Hopkins, and using that tracking badge study, we asked people, how much time do you think you spent with patients compared to how much time you actually spent with patients? Everyone overestimated their time with patients, but there was an inverse correlation between how much time you thought you spent with patients and how burnt out you were, right? So thinking or being present with patients, spending more time with them probably is a vaccination against burnout. The last thing I'll say before I turn it over to questions is what we want to do is build community. And so this is an example of one of the Stanford 25 symposium where we would do these pictures on the steps. And there's a couple ways to do that. So through the Society of Bedside Medicine, we have a bedside scholars program funded by the Gordon and Betty Moore Foundation, where every year we give out two $40,000 stipends for junior faculty and fellows to do their own bedside medicine projects at their home institution. We just selected our two scholars for this past year, or for this upcoming year. The next cycle will be in the fall. I would love next year, and I'm saying this to all the Stanford 25 faculty, we should have a Stanford person have one of these awards next year. Yeah, and tons of applications from here. These are our two scholars from this year. The other thing we're going to try to do is, we were so inspired by what you guys created here. We're going to try to reboot it again in Chicago this year. So mark your calendars, November 14th to the 15th, co-sponsored with the Center of Bedside Medicine, the Royal College of Physicians of Edinburgh, and the Society of Bedside Medicine. We're going to have a conference in bedside medicine. Since John and Errol are helping me to plan it, and Sonu as well, you're going to recognize some of the awesome things that you guys did, and hopefully we'll be able to rebuild that community through there. So in conclusion, hopefully I've convinced you the bedside encounter is still important, that deliberate practice and evidence-based approaches will improve our clinical skills. Assessment's important and does drive learning. The road back to the bedside involves technology, and I'd love to work with everyone here to continue to build a community around this. I'd like to thank our graduate medical education laboratory. Most of the data I showed you is from this consortium funded by the AMA that included Stanford, UAB, Hopkins, and now Northwestern, and of course our Society of Bedside Medicine. And too many people to thank here who really have helped me figure out how I want to engage in this community and to continue to build it. So I think I'll stop there. Thank you.
Okay, great. We have a lot of questions already online as well. Let's start in person here. Dr. Reiniger.
Thank you. Thank you for that. I'm Ann Waneker. I'm a pulmonologist. I spend my time in the ICU. And I've been practicing medicine for decades, so I trained decades ago. And so everything you're saying resonates incredibly with me. And I've joked often, only half joking, that I could hide a kitten in the bed sometimes and the house staff wouldn't find it, because it's so technology driven. My question is a little tangential, and it goes back to one of your early slides when you showed the four house staff sitting in front of a computer. And I wonder if you had done these same studies in terms of how much time people spend doing various things, how much the EMR has actually added to what we do, or actually made our lives a lot easier. I know, having done all of what I've done trained way before anybody ever thought about an EMR, that we would spend our time on the phone calling other hospitals to get data, we never could, we go to the lab to find the last labs they had, et cetera.
Yeah.
Do you have a sense, or are there studies that actually look at how much the EMR has taken us away from the bedside compared to what it was like when we actually had to run all over the hospital to get all these things and then write our notes de
Yes.
novo every day?
There are not many studies about this. There's a study from Yale from like the late 1960s. It was like 2 interns that people followed. And they spent about 23% of their time at the bedside, right? And then there were some studies in the 80s, which was about the same, was about 20%. So there's definitely been a decline, probably about 10% over the last 20 to 30 years. How much of that you can attribute to the EHR versus, obviously the benefit of having an incredible amount of data available at your fingertips. There's certainly, I don't mean to, disparage the EHR. I don't think it's the sole reason for our change in focus. But certainly I think the documentation time has increased. And one of the hopes for AI is that maybe some of these ambient learning, ambient technologies, listening technologies will help us to document more effectively. What I fear and what we've seen in some health systems that have employed these is great. You can actually get your notes done faster. Now you should see more patients, right? And so the added time that we could have spent engaging with our patients about, shared decision making or navigating uncertainty, if we're not careful and if we don't raise our hand and clearly express that we want this time for other things, we will find ourselves being more efficient and having to see more patients, and nothing's going to change.
Yeah, I completely agree with that. I think we've been eroding for decades, even longer than that, as you showed in your slides, our ability to do physical exam, because we couldn't do what our older faculty could do when I was a medical student. But I remember a lactate that nobody could explain until somebody pulled back the sheet and saw the patient had an ischemic limb. So, and that was, I can tell you how many years ago, but it was decades. But thank you. This is really wonderful.
And I do want to say one thing, we're talking about sort of the decline in skill and the way our trainees spend their time. This is not, for the trainees in the room, this is not the environment that you guys created. So this is not, in some way a knock on your abilities. You guys are smarter than you've ever been. The things that people have done prior to coming to medical school and coming to residency are just unimaginable 20 years ago when I was applying to medical school. There's no way I would get into Johns Hopkins Medical School today. With the stuff that I did during medical school. So it's really just about harnessing some of that incredible firepower and curiosity and just shifting a little bit of it towards some of the information we can get from spending more time with patients.
Thank you so much for your talk. I'm looking around, there are a lot of trainees in this room and a lot of people who are on wards or similar inpatient rotations. And after this talk, we're going to go back and round. And I was wondering if you had a perfect sort of script of how rounds could go that would maximize learning at the bedside, but also not impair sort of efficiency, getting consults in, moving care forward at the at the computer. So sort of walking through a perfect round structure.
So you made my answer very easy. I do not have the perfect solution, right? So when this has actually been studied, Jed Gonzalo has done a large study on this, comparing like dedicated bedside rounds versus sort of traditional whatever people are doing at their home institution. It really doesn't add much time to intentionally go in and spend time with patients, as long as you have some sort of structure and some shared idea before you go in the room. What do I want to accomplish, right? So for example, if you're seeing a patient who's short of breath, you probably want to decide outside the room, hey, what are the 3 or 4 things we're going to look for together, or questions we're going to ask before we go in the room? And so you can prioritize those. And then that will leave time to talk about what those findings are in the room with the patient, and then ask the patient about, what they think their diagnosis might be. A lot of it, people have written about doing choreography. So assigning different people specific tasks. So, it could be that you guys, I know John's worked a lot on this, and how do you use the EHR more effectively? We've all probably read the HPI. So we don't have to have the medical student read the entire HPI to everyone before we go in the room. We can just remind everyone, hey, this is our patient who presented with these 3 things, maybe a snippet about who they are as a person. And then you can focus on what additional information do we need to gather, either from the history and physical, before we go in the room, having that plan. But then also being willing to just follow whatever happens once you get in the room. That's the beauty about the bedside. You have no idea what's going to happen when you walk in that door, right? But I would challenge you to try it. And yes, it takes practice, but once you start doing it, it doesn't take as much time as you think. And the rest of your day is actually freed up because you've made decisions, you've decided calling consults, and you don't have to go back to repeat the abdominal exam that you thought you should do, but didn't have time to do when you first saw the patient.
We'll go to Dr. Vasquez next. Just really quick, there's a lot of questions online as well. I'll go to online next. Please upvote for the ones online. I'll pick the one most upvoted. Dr. Vasquez.
Very quickly, thank you very much. And I want to say that I find it incredibly inspiring how trainees are really hungry to learn and to see and to feel more comfortable with physical exam. Simple things like the subtleties of blood pressure measurement, thyroid exams, rectal exams. And we see that so many diagnoses get missed by not doing a simple rectal exam and getting that confidence. And I just wanted kind of to thank you because I think the small time that it takes to model and for us to train the trainees, I think the importance of modeling is so important that the students and residents just say, my God, now I know how to hold that ophthalmoscope. Now I know how to do those things. And so thank you, because I think that all this time, it doesn't take that much time and the students really benefit and grow, and they don't want to become third-year residents and not be comfortable with saying, I really don't know how to do that. So thanks again.
Well, it's my pleasure. And thank you, because honestly, the groups here who have done this work for many, many years really have inspired me to try to chart my own path here.
Thank you for all the upvoting. The one that's winning right now, Dr. Nguyen, our division chief of GI, she asks, the convenience of telemedicine has led to a rapid adoption of both patients and clinicians. How do we bring bedside medicine into this high-tech world, and should we resist this trend?
Yeah, so I'm looking at Maya Artandi in the audience here, who has written a lot about a patient-partnered physical exam over telemedicine. So I think a lot of what we do at the bedside is observation. And one of the amazing things about telemedicine is you get to observe people. You still get your visual input, you get your audio input, but you also get to see them in their home environment. My favorite telemedicine visit during COVID was a gentleman who had interstitial lung disease, and I noticed he had a banjo on the wall behind him. And so, we had finished our medical stuff, and then he took down his banjo and I took down my guitar and we just played. Right. And that relationship that I had with him would never have happened in the regular office. I had no idea that he played music. So I think there are things that we can do. Technology can be helpful here, right? Obviously there's barriers to technology and who has access to it, but pulse oximetry at home during the pandemic obviously has problems. Our group has thought about, racial disparities in pulse oximetry, but still provide you pulse data, oximetry data. As digital stethoscopes become more accessible and less expensive, it's possible that some people might have access to have a patient-guided stethoscope exam at home for certain complaints. And there are some companies that have tried to do that, some more successful than others. So I think telemedicine has value, and understanding when it's time to bring someone in person because there's something I can't do just over the camera. I think that's a real skill set that we need to learn, because before COVID, not many of us were skilled at doing a telemedicine exam. And I don't put myself in that category as being skilled at it.
Thank you. I know we have a ton of, tell us how important this is. We have so many more questions here and ending, but we're at a minute to end.
I will answer anything on email too. So if you want to email
or
me.
Perhaps after as well, but perhaps I'll ask Dr. Fatesi to come and help close us out. He has I see a gift here for you.
I'm just going to take a moment to present you with the Kovitz Award, and thank you again for joining us, for setting a model of both how we should practice medicine and, importantly, how we should treat and help educate our next generation of physicians. So thank you very much.
Thank you.
Really great. Thanks so much.
Thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.